On behalf of the American Heart Association, I would like to welcome you to the final session of today's Close the Space, Secondary Prevention of ASCVD Care Education Virtual Summit. My name is Natasha Chiafalo, Programs Consultant at the American Heart Association, and I will be your moderator for today's session. All presentations will be recorded and available within the coming weeks at heart.org/ASCVD. It is my pleasure to introduce our final speakers for today, Dr. Marco A. Gonzalez Castellon and Dr. Carrie Hoarty. Dr. Gonzalez Castellon is an associate professor in the Department of Neurological Sciences at the University of Nebraska Medical Center. He is board certified in neurology and vascular neurology. A native of Panama City, Panama, Dr. Gonzalez graduated from the University of Panama School of Medicine in 2000. He completed his neurology residency and vascular neurology fellowship at the New York Presbyterian Hospital Columbia campus in New York City. Dr. Gonzalez currently serves as the director of Nebraska Medicine Telestroke and leads the DONS Stroke Fellowship. Dr. Carrie Hoarty is an associate professor in the Department of General Internal Medicine at the University of Nebraska Medical Center. She trained in a joint pediatrics and internal medicine residency program at the University of Nebraska Medical Center, where she subsequently completed her geriatric fellowship. She is board certified in internal medicine and geriatrics with the American Board of Internal Medicine, as well as pediatrics through the American Board of Pediatrics. Dr. Hoarty is the medical director of the Internal Medicine Residency Continuity Clinic at UNMC. She enjoys caring for all adult patients, but especially older individuals with geriatric syndromes, as well as those with special developmental needs. Dr. Gonzalez and Dr. Hoarty, the floor is yours.
Thank you. My disclosures, and I'm a member of the AHA Stroke Emergencies Committee, and also I'm a member of the AHA Spanish Stroke Warning Signs Committee.
And I have no disclosures. Thank you, Natasha, for the introduction. We're both at conferences, so we're happy that we can kind of double dip and do this as well. So our topic today, and Dr. Gonzalez, I'll let you kind of advance the screen. Our topic today is maintaining health equity for atherosclerotic cardiovascular disease in rural areas. So we'll cover health equity, disparities that exist between individuals living in urban and rural communities, as well as approaches that we can take, both traditional and novel, to reduce these disparities. And we'll talk about strategies to maintain health equity. So when you leave here today, we hope that you understand the disparities that do exist and understand that these disparities and not having quite as adequate care and treatment for those in rural areas do have consequences and end up costing us more. And then we can talk about what our role as healthcare providers are in reducing these disparities that exist. So let's talk about what health equity is. Health equity is the attainment of the highest level of health for all people. And this requires valuing everyone equally with focused and ongoing societal efforts to address all avoidable inequalities, both historical and contemporary injustices, as well as social determinants of health, and to eliminate these disparities in health and in healthcare settings. And this can be handled and approached on both the community grassroots level, as well as from a federal standpoint too. There's lots of disparities that exist within healthcare, and so these can range from disparities that stem from racial and ethnic minority groups, differences in care given to pregnant or postpartum women with hypertension, individuals with disabilities or lower socioeconomic backgrounds, individuals who have behavioral problems or health issues that result from tobacco use. But the area we're going to focus on today is people who live in rural areas and other what we call access deserts. So areas that are void of appropriate health care to address the atherosclerotic cardiovascular diseases that exist. This is just an image, something that Dr. Gonzalez or I might see if we drive a half hour in one direction or another. We're in Omaha, Nebraska. Omaha and Lincoln are fairly metropolitan and urban, but many members of our community live in a rural life, and there's vast space that separates neighbors, and getting to the grocery store or school or to the doctor's office or hospital requires quite a bit of distance. So one of the things we love about Nebraska is the space we can see if we just drive a half hour. But this is an example of where we live. There's significant disparities between urban and rural locations regarding cardiovascular disease. And the rural population is a huge portion of our population in the United States. It comprises of 60 million people, or 20% of the US population. It's important for us to understand and work to address the unique needs of these individuals so that we can decrease disease, morbidity, and mortality. And this is one of the American Heart Association's unique challenges right now, is a pursuit of a world with longer, healthier lives. The Office of Management and Budget, for example, defines rural counties as those with an urban core of greater than 10,000 but less than 50,000 individuals, or a county that has no urban core at all. So no like town center, no little city. In general, we find the individuals who live in rural locations to be older. The population growth rate in these areas is lower. Higher poverty exists, and it's a bit of a more racially homogeneous group that lives in rural areas. In the last 3 decades, the gap in health outcomes between those living in urban cities, metropolitan areas, and those living in more rural, less densely populated regions has really begun to separate. In the 80s, mortality was pretty similar. You can see in the 70s and 80s on this graph here to the right. And in 2004, we're seeing a little bit of a separation that in more rural areas, about 77 more individuals die per 100,000 individuals per year. And then by 2016, we're seeing 134.7 more deaths per 100,000 individuals in more rural areas. Life expectancy is also decreasing in these rural areas. By 2014, individuals living in rural areas is down 3 years compared to urban counterparts. And for Indigenous individuals, it's 5.5 years less. The 2017 National Health Interview Study showed a higher prevalence of heart disease amongst individuals living in rural areas, 14.2% compared to almost 10% in rural areas. And so this leads to higher death rates from heart attacks and strokes. There's a significant increase in stroke mortality amongst individuals living in rural areas by 30%. Also, we see a higher maternal mortality rate driven by cardiovascular deaths. The second slide here that I'll show you next will kind of show, be a little bit more illustrative, but despite public health and policy efforts, as stated before, the gap is widening between mortality between these areas, rural versus urban. And we're not really sure if it's because of hospital level care, because of decreased acuity and ability to care for individuals who have acute cardiovascular conditions such as MI, stroke, heart failure. But there is a decrease in mortality and decreased treatment options between rural and urban settings. This might be related to differences in the resources, capabilities of smaller town hospitals, or the lack of availability of these facilities for many reasons. The Medicare provider analysis and review files from 2016 to 2018 show that patients in rural hospitals are less likely to receive procedural care, which I'll talk about in the next slide, which led to higher mortality rates in rural hospitals for heart attack, stroke, and heart failure. These are most predominantly seen in the west, north, central regions such as Iowa, Kansas, Minnesota, Missouri, Nebraska, South Dakota, and North Dakota. So we see the greatest 30 and 90-day mortality in those conditions, and I can show you on the next slide. So the blue line shows level of interventions received by individuals in rural hospitals, as opposed to the red bar. I'm looking at the left ones. The red bar represents interventions provided to individuals who present to urban hospitals. So we see that both cardiac catheterizations, percutaneous coronary interventions, coronary artery bypass grafts are provided at a greater rate in rural areas. And then for CVA, systemic thrombolysis, and endovascular therapies are greater in urban city settings. This translates on the right to greater mortality in those who do not get the interventions. So in rural areas, we see the blue bar being higher, or mortality being greater for MIs, heart failure, and ischemic stroke on top, and then on the bottom, similarly. These are 30 and 90 days, so greater both in rural areas. Of course, receiving inadequate or late treatment for atherosclerotic cardiovascular disease has a great cost. Early treatment is associated with a reduced risk of ASCVD hospitalization compared to those treated late or not at all. And you can imagine someone presenting in late heart failure or with significant sequelae of poorly or untreated CVA or acute MI would have significant greater costs of treatment. If you do treat atherosclerotic cardiovascular disease, you do have higher costs of treatment over that first year, but in the long run, it's lower. We did see that LDL-C levels greater than 130 were associated with higher hospitalization from ASCVD. And the greater we reduce the LDL, the greater the cost reduction. The problem is limited access to ASCVD both primary and secondary prevention among rural patients, not only because of distance to traveling to their physician, maybe decreased access to pharmacies, decreased testing. So obviously less decrease in primary prevention leads to greater atherosclerotic cardiovascular disease, strokes, MIs, and increased need for secondary prevention. We stated earlier, that individuals living in rural areas have increased poverty rates, older population. So some of these unfavorable social determinants of health are associated with higher burden of excess financial strain with these individuals who have atherosclerotic cardiovascular disease.
Okay, thank you, Dr. Horty. So I'm going to try to kind of talk about what can we do about these differences. I think the first step to understand these differences, we want to know, and we want to understand why these patients, being similar populations, have these significant differences between the rural and urban settings. The American Heart Association has been very interested in understand these differences, and in 2020 release a call to action to understand these differences and propose mechanisms to close these gaps. The underlying causes for these poor cardiovascular outcomes in rural America have many aspects. We cannot forget about the individual factors for each patient. We also have to remember there are some social determinants of health as well. In terms of rural factors, we know that patients in rural areas tend to have higher rates of uncontrolled diabetes, uncontrolled hypertension, and hyperlipidemia. Culturally, people in rural areas tend to be more self-reliant and only go to medical facilities only if they have a disease or a condition that they cannot handle on their own at home. So sometimes they present to the ER only after a major event has happened, such as a stroke or a myocardial infarction. So cultural reasons are there, and also higher prevalence of non of chronic diseases such as diabetes that were unfortunately sometimes undiagnosed until a major event happens. Other underlying causes include the determinants of health. People in rural communities unfortunately tend to have lower income, which makes it more difficult for them to access medical care. Some of the things that I learned after moving to Nebraska is that sometimes just the fact that they need to drive 2 hours to come to the doctor becomes cost prohibitive. Usually they have less access to transport, and those who have cars, just the cost of gas and fuel can be sometimes a limitation for them to access primary care and specialized care. All the things that are a factor in the social determinants of health is access to healthy food. It's kind of it's interesting that these patients who are mostly farmers and produce most of our food sometimes live in areas where getting high quality food might not be so easy, and also the prices can be exclusionary to them. So access to more healthy food might be problematic even in rural areas. So all the things that I want to touch bases, and one of the things that we can actually make a significant change is in the delivery of care. And this is important because with modern technologies, we can overcome some of the social determinants of health without incurring an excess cost. For example, patients in rural areas, they have availability of care, but they usually is provided by smaller hospitals that unfortunately have less patient volumes and less capacity to provide critical care. These hospitals usually do have higher levels of satisfaction, and not everything is bad in rural hospitals. Patients report higher satisfaction, and actually they do have smaller or lower infection rates. But unfortunately, these hospitals, the experience they have and the capacity to offer specialized care is limited due to the fact that they have less funding, and the reimbursement sometimes is not as high. Unfortunately, in the last few years in the United States, also there has been multiple rural hospital closures, which will also reduce the availability of facilities for these patients. So not all the quality is bad. It's just that they have lower margins and they're not able to offer the latest treatment to these patients. Another thing that I did talk about briefly is the distance to the hospital and the mode of transportation. In rural America, 911 services and EMS services are usually done by voluntary crews. So these are community folks who are committed to their town, but they have other jobs. So for a patient with an MI or stroke, calling 911 might not be the easiest way to get to the hospital, just because the ambulance probably is in another town, or the person or the crew that drives the ambulance actually is in another job, so it takes them longer. So sometimes they have to find their own way to get to the hospital. Not only that, is that the majority of patients who live in rural communities, they have to drive longer to reach a hospital that can provide the adequate care. Driving to a PCA-capable hospital in a rural community can take up to 2.5 times. And for something like stroke, where time is of essence, we can see multiple patients arriving outside the window, and not because they were not able to detect the symptoms, but it just took them several hours just to get to a capable hospital. Other things is that once you treat those patients, is that you have very difficult post-acute care and outpatient care. There's a significant limitations in availability of primary care follow-up, and also availability of specialized post-acute care like cardiac rehab and physical therapy, occupational therapy for those patients after a stroke. Another issue that it's pressing is the shortage of rural clinicians. In the last 10 years or so, there has been a significant reduction of U.S. physicians practicing in rural areas, despite a good percentage of the population living in these areas. Today, only 9% of U.S. physicians actually practice in rural areas. And most of these physicians are generalist. In fact, in the United States in 2016, 77% of all small counties and rural counties report that they have a primary care physician shortage. And not only that, there is also shortage of nurses and other health professionals, making delivery of care more difficult for patients. So unfortunately, not only they live very far away, they have more uncontrolled risk factors, but also there's less access to pharmacists, therapists, physicians, and other healthcare professionals. So we can see that there is a significant shortcomings in terms of the differences between the care of those patients who are in the rural areas. And it's not only factors that are associated to the patient, but also factors associated to the system. So how can we solve this? And the purpose of my talk is not to talk excessively about the possible solutions, but to give you an idea of things that now are available and that we can improve in terms of increasing the access to healthcare and closing that gap. Of course, the first thing that comes to mind is to expand the healthcare force, but that is not so easy. Most patients and schools have limited, either nursing school or medical school have limited slots, and not all those folks who and those candidates to go to these schools are willing to move to a rural area. So one of the possible solutions that we can have is supporting those schools who have a rural mission. There are schools that provide discounted or repayment of medical school and nursing school costs if they move to a rural area. So that should be supported. And another option that I want to talk a little bit more in the next few slides is about digital support of the healthcare and other alternative ways of providing healthcare. And I think that has to be supported by new models of care delivery. And I think that sometimes we can close those gaps and improve the care by just having the right patient going to the right health professional. And as the prior talks today sometimes we have to take advantage of our pharmacists and other healthcare professionals to close and improve those patients, health of those patients. All the things that we can talk about and are food for thought is improving the funding of healthcare facilities in the rural areas, and this is very difficult. And the last is increase the amount of research to understand the current gaps and propose solutions. So the last thing I want to share is this interesting approach, and I think it's this can help as an example, can have illustrate an example how new technology actually can help closing that gap. We already know that these patients in the rural areas tend to have higher rates of diabetes, uncontrolled diabetes, hypertension, hyperlipidemia, and that also they have more difficulty in accessing care. So one way to do this is by participating in performance improves quality projects. And another one is using these technical interventions like the one I'm going to show in this slide. So basically, this is a study that it was done in conjunction with the Information Technology Office in Mayo Clinic. And they realized that sometimes patients do not need a appointment with a physician to sort the problem that is hindering their reaching those goals in terms of LDL and managing their hyperlipidemia. So they realized that sometimes just by directing the patient to the right healthcare professional might be all that is needed to improve and achieving those goals. So they came up with a CDS tool that would read through the chart and look for those patients who are not meeting the standard guidelines. And they realized that checking for LDL levels, glucose levels, hemoglobin A1C level was more straightforward in health electronic records. Once they identified those patients, if they were accessing the portal, they would get a survey that would ask if the patient was taking aspirin, the patient was taking statin, and if they were taking a statin, how much and how, what was the dose. After getting that information, the patient would get a verification call to make sure that all the information was accurate. And then after that, a sorting algorithm will match that patient with the appropriate person. For example, they were patients that the only thing the issues they were having is that they were not sure how to take the medication or what time. So something that a nurse can discuss with the patient and instruct them how to take the medication. Sometimes it was just needing for them to meet with a tobacco cessation coach. Sometimes the question or the problem was more complex and they needed a provider to counsel them. And sometimes it was just the pharmacist who was needed for understand interaction with other medications. The pharmacist can help us understand the polypharmacy because all these patients are taking several medications. So by doing that match process, these patients were able to actually improve their goals, improve their numbers. And because it was done by matching them through a online tool through their phone, all those barriers of distance, access, and were bypassed. And so patients would get more rapid information and intervention in terms of their overall care. So with this study, and I think this was a great introduction to all the things that we can do by partnering with our IT colleagues and professionals, how we can use new tools and the availability of smartphones to start and use a team-based care model where the patient can have readily accessed, and the right questions directed to the right person in the team. And usually this in the future, hopefully, will be one of the ways that we can close the gap in these patients. Also, with access to internet being more available to patients, we can increase and increase the access to the appropriate professional. And with that, we move on to questions.
Thank you, Dr. Gonzalez and Dr. Horty, for your presentation. I do have some questions, and I'll just send them your way. The first question is, with the shortage of the healthcare workforce in rural areas, how do you address caring for individuals post-MI or CVA test?
Thank you for that question. So many contributors to that. Dr. Gonzalez kind of presented some novel approaches using AI, but also using primary care physicians for either their offices or providing them with the recommended, follow-up is one option. Other novel approaches could be having individuals go to a city center, library, grocery store that might have Wi-Fi telehealth options with, or pharmacy locally that has access to blood pressure cuff, and then doing telehealth options with the cardiologist or neurologist back in the city where they were hospitalized. Other options would be sending patients home with remote patient monitoring where they can check their weight, blood pressure, pulse, all those things, and doing closed telephone follow-up with nurse care coordinators or follow-ups with their cardiologist or neurologist that they saw in the hospital. As we all know, practicing medicine is an ever-changing field. And so sometimes individuals who are not able to do CME might be using outdated guidelines. And we know that, the American Heart Association's recommendations and promotion to get with the guidelines and get LDL-C under 70, maybe not all rural physicians and PAs and nurse practitioners are aware of that target goal and all of the modalities, the statins, the ASCVD and the PCSK9s that can be used to get to those goals. So continuing education for the rural providers is really important. So there's lots of novel approaches we can take to reach these patients, but making sure that they have access to care at discharge is really important.
Wonderful. Our next question, you showed us how delaying care can increase cost and is associated with worsening outcomes. How can we encourage rural patients to seek preventative ASCVD care?
I can answer that one, or Dr. Horty, you want to answer that one?
Either way is fine. I think, really education, and we can use local institutions such as churches or community centers. Sometimes even the industry sponsored information, getting information to patients about the signs of stroke and the signs of ASCVD and when they need to seek help immediately. But as you said, even when they do seek help, sometimes just transporting themselves to care already puts them outside of timelines for certain interventions. But education, I think, initially is the most important thing. Obviously, we'd love to swim upstream and do primary prevention and make sure that LDL goals and diabetes and hypertension, all those things are addressed. But just, I think that the education as far as signs of stroke and signs of MI, teaching individuals is really important.
Yeah, I wanted to add that in the initiative from the American Heart Association, they recognize the role of lay healthcare workers or educators and like the healthcare ambassadors. And I think that's something that I found very interesting. Have, their hairdresser or anyone in the community who has a lot of contact within the community start conversations about make sure you check your glucose once a year, make sure that you don't have diabetes, make sure you check your blood pressure at least once a year to make sure that you don't have hypertension and seek appropriate treatment. So that's another resource that are, folks within the community that we can actually tap into and just, remind them of lifestyle changes and so on.
Yeah, along those lines, we got a comment from one of our participants. We have somebody in our group that practices nephrology and internal medicine for CKD patients in a rural area. They see a missing link in the chain of care, which is availability of nutrition specialists, dietitians especially. None are available in their town. And she has to send patients 50 to 60 miles away. It should all begin with the food that patients get, with all due respect to pharmacologic agents and invasive procedures. She states, from a medical standpoint, physicians have full access to knowledge as if they are in urban areas. For example, patients eat sausages for breakfast infrequently, beef jerkies, etc. Restaurants have no healthy options. I wasn't sure if you have any reflections on that, and there are also more questions that we have on our list.
I would agree. And even at University of Nebraska Medical Center, dietitians come and go. And right now we participate in patient-centered medical home, and one of the team members is a dietitian. And so that person can, we can refer patients, but even that person turns over, and then we're without a dietitian for the whole system every once in a while. So that is difficult, but we can refer in our community to our local grocery store has dietitians. So sometimes we'll rely on those individuals. And again, like Dr. Gonzalez said, lay individuals who kind of develop an expertise can help disseminate knowledge as well. And even handouts from primary care doctors. And I feel like I've developed like a 30 to 50-second spiel on foods to eat, foods not to eat, what to avoid, what to emphasize. So, every single thing we add on to our spiel takes time, and then that means we see less patients. But, I do think us physicians need to take that dietary recommendation and let patients know what that can be doing to their arteries and then brains and hearts.
Yeah, I agree 100%. I think food as medicine, and that's a campaign that AHA is gonna started this year, at least in the stroke meeting, that we should think what we eat as part of our treatment. And I do spend a little bit of time, but with patients discussing about nutrition. Ideally, we should refer, but for example, for the neurology clinic, we only have one dietitian, so that is kind of hard to get them in. And but definitely that's something that we should take into account. And I agree 100%. Food is very important.
Great. Our next question. In your presentation, you mentioned that rural hospitals have reduced capabilities and resources. What measures can be started by rural hospitals to improve their capability without being cost prohibitive?
Yes, and as a telestroke director, I have to say that participating in a quality improvement program, such as Get with the Guidelines, or being part of your local academic center in terms of the stroke center or the cardiovascular center, usually is the first step. We have visited many hospitals, rural hospitals, who are not treating patients with stroke or have very low treatment rates. But once they join our telestroke network, not only they get the expertise via telemedicine, which represents an investment, of course, but also they can participate in our educational seminars and programs, and that usually improves the quality of the care that they provide. So I would recommend that if you are in a state that has telestroke, look into it. There are some initiatives that sometimes are funded by the local government or the state government. For example, telestroke was funded by the local Arizona state government for many years, and patients would, hospitals could benefit of the expertise and being paid by the local government. And there are many ways to fund this through governmental entities. So to answer your question, I would definitely look into partnership with a local academic center to provide expertise and get education and advice and care of these patients. And that usually drives the improves patient care delivery.
Great. One last question. What role does telestroke and other enhanced consultation modalities play in reducing disparities?
Well, I think kind of mentioned in the prior question, but telestroke and like teleneurology, teleendocrinology have shown that not only increases access but reduces disparities by having more patients meet or receive the treatment that they need, and also improves the chances of those patients meeting the goals. And atherosclerotic cardiovascular disease, is very important that we achieve not only LDL levels, but also achieve adequate blood pressure control and diabetes control. So by having access to patients, to an endocrinologist and neurologist, is vital for them to reach those goals.
Well, thank you, Dr. Gonzalez and Dr. Horty, for your presentation, and thank you to our audience for your participation. That is all the time that we have for today. I just want to say thank you to all of our excellent speakers and presenters, and to all of our participants for your thoughtful questions. After you exit this session, a feedback survey will pop up in the lobby. The recordings for all 6 sessions from today's summit will be available on heart.org/ASCVD in a few weeks. Please be sure to check out this website for current and future educational opportunities or to join our mailing list. We want to thank you for your participation, and we hope to see you soon at our next event. Thank you.